So my talk on the intervention in the peripheral artery disease. This is very generally going to the basic anatomy, pathophysiology, and there is some certain risk factor. And if you are studying the peripheral artery disease, you have to not only jump directly into the intervention, you have to understand the pathophysiology of the disease also, why it is happening. That's very important to prevent the recurrence and for the treatment point of view. So before you can start certain medication, that will help you in the treating the patients. So you can lower down the as much risk factor before treating the patient. Like smoking, you can BP control, smoking, suggestion, lipid control, any patient is diabetic, the proper glucose control. So these things are very important. That before directly jumping into intervention, you have to understand the biology of the patient. How is the patient is, what is the etiology of the disease? So this is very important to know the disease etiology of the patient. What is the main factor that is causing the peripheral artery disease in this patient? Whether this is valvular disease, whether it is thrombotic phenomena, whether this is atherosclerotic, or what is the current biological profile of the patient? Like what is the lipid profile, what is the blood pressure level and diabetic profile? So you have to balance everything before putting the patient into intervention if this patient is critical ischemia. When a patient is acutely ischemia, then you have to treat it anyway. But when a patient comes to critical ischemia, then you can lower down the risk factor as much as possible, so you can get a better result after intervention. So this is the basic anatomy that everyone is aware of. This is the we have the common iliac artery, external iliac artery, and the femoral artery, and these are the anterior posterior tibial artery, and then this is the profunda. This is how this is dividing, making the dorsal arch and the plantar arch. So everybody is aware of this. So we have now because this is important, because we have to know, we must be aware how we have to at least one below the knee, we have to make a flow in at least one of the artery, whether it's anterior, posterior tibial or peroneal artery. We have to make a flow in one artery to heal the ulcer, whether this is targeted or non targeted. The pathophysiology around what is the certain risk factor, smoking, as I already discussed. We have to look for these causes, and we have to treat these cases before going for the intervention. So that less recurrence is there and more good results are there. The patient may be asymptomatic, maybe classical claudication, maybe atypical leg pain. These are the various mode of presentation of the patients. So we have to take the history of the patient. It's very important to understand every patient is different in this case. So we have to understand whether the patient having symmetrical disease or not, whether the patient having coronary artery disease or not, whether the patient is smoker, history of claudication, any previous intervention is there or not, any cardiac intervention is done or not, what medication is patient on, and what any history of trauma or. We have to do the physical examination just by the clinical examination also, and Doppler examination also, and we have to look for the pulse, paralysis, paresthesia. And patient is diabetic, patient is having ulcer, so we have to rule out whether the cause is neurological or vascular cause. It's very important. So we have to send the patient to the neurology for the neurological study for whether the nerve conduction velocity is normal or not, whether patient is having no diabetic neuropathy or not. So we have to rule out before doing any vascular intervention. This is very important. So you have to achieve a diagnosis. Okay, this is the cause is vascular only, not the neurological cause. So this is very important to try to get, especially diabetic, to try to get the NCV done if it's coming normal or not, then proceed for the vascular intervention. So maybe the cause may be neurological, we are taking the vascular, we are not getting any result, or rather than getting this patient done, we are further complicating the patient. So NCV is must when we are doing such cases. So first we have to non-invasive like ankle index, color Doppler imaging that we can perform in every patient, CT angio, MR angio, and invasive we have to doing the procedure only. This is a basic classification. We generally use the Rutherford classification used by the patient asymptomatic grade 1, grade 2 3 mild claudication, moderate depending upon the distance of the patient, grade 3 is severe claudication, the ischemic rest pain, the minor tissue loss, ulcer or gangrene. These are the grade 1 to grade 6 or Rutherford. These are more clinically acceptable. So first is the risk management. I talked earlier. First is the risk factor modification. Smoking cessation, glycemic control, diabetes, blood pressure monitor. This is very mandatory. Don't take straight with the patient to the lab and start with the patient. Before control these parameter before taking the patient. Put the patient on the antiplatelet drugs, and anti-statin drug. Cholesterol has shown the good result. This is the only drug that has shown the result with the claudication only, cholesterol. pentoxifylline some add, but we can add the pentoxifylline. But it does not show some result, but not so proven result with pentoxifylline. But silestazole definitely show the result with the claudication distance. These are TCS criteria for the classification of the PAD. Once we get the CT angio done, so after CT angio, we are able to whether the patient is finding in which category. So based on the category, we can define whether we can send the patient for surgery or directly for the intervention. So nowadays, in every category, we can straightway go with the intervention. When it fails, we can go for the surgery. Even in the generally it's recommended in type D lesion, we have to go for the surgical evaluation first. But now we are treating type D lesion also because the hardware is improved a lot. We have lots of improving the catheter and guide wire technology. So even in the state type D lesion, we are able to do by endovascular approach only rather than surgery. So this is the type A lesion, less than 5 centimeter, less than 10 centimeter occlusion, type B lesion based on this. The type D lesion generally will include the BTK disease, popliteal trifurcation, and more than 20 centimeter segment of the SFA. Yeah, any artery involvement is a type D disease. So these type D diseases are very difficult to treat. Most of the time we are get only type D cases only in actual practice. When the patient comes, whether it is a Berger disease or atherosclerosis, the most of the patients are falling in the category of type D. Because most of these category are already dealt by the cardiologist or some other vascular surgeons and CVTS surgeons, and they left only type D because they cannot do anything in that. So we are left only with the type D lesions. Because maximum time I found the cases of all the cases are type D disease only because they can't do anything in type D cases. So we must see how we can open such a large block. What are the different techniques and how we can manage it by endovascular approach, by doing minimum complication, or keeping the patient at that stage only, rather than worsening its Rutherford grading or its vascular grading. The technique is surgical thrombectomy, surgical bypass, endovascular catheter ductal thrombolysis, that is for the acute limb ischemia, mechanical thrombectomy, that's for acute, angioplasty and stenting for the critical limb ischemia and claudication. Tools for the percutaneous circulation, I am aware of that. We are doing balloon angioplasty and we are doing stenting. After that, if flow is not established, the different stents are available, across the joint stent are available to look for the flexibility. Now coming to the cases, because my presentation is more of the case presentation rather than the theory. This is a 50-year-old male with history of blackening of the left toe and resting pain in the limbs since 3 months in the Department of General Surgery, and was referred to us. Past history of smoking more than 20 years present, no any other comorbidities present, no previous treatment history. Doppler revealed low flow monophasic waveform in the right lower limb arteries. CT angiography revealed the left external iliac artery, known ossification extending up to the left common femoral artery, along with the known visualization of the ATA, PTA, and dorsal pedis artery. So these patients are also these are the patients we are getting in our practice, because these patients are also have the inflow disease and the outflow disease also. So this is also the disease of the external iliac artery, common femoral artery, and the disease of the BTK disease also is present. So this is the internal iliac artery. This is a blocked external iliac artery. We are not able to visualize any artery below the hip joint because distal deformation is somewhere in the distal femoral artery, and below that there is a certain BTK disease also. We are not able to visualize the ATA, PTA, and nothing else. So in such cases, we treat the patient generally in two stages. In first stage, we only do the inflow disease treatment, only the to increase the outflow to form the collateral and to increase the vascular bed in the distal runoff. So the first stage is to only to treat the inflow disease first. So this is the thrombosed. We have the thrombosed femoral artery here. So we took the retrograde approach from the thrombosed artery and went into through the thrombosed artery. We have passed the guide wire, came into a true lumen, and we also have the cross puncture of the right femoral artery also to see whether we are in the true lumen or not, or we are able to see when the guide wire is coming to the patent part of the external iliac artery, whether it is going to true lumen or not. So this is very important to take the both approach. So this right approach can tell you when you are coming to a true lumen, so you are not coming into the directly into the aorta or directly into the common iliac artery. So we are you must be sure that by contrastification, we are coming to the patent part of the external iliac artery. So we can see by road map, we can see we are coming into the, this is the patent part of the external iliac artery. Or we can see the after passing, don't pass any catheter. Once you are sure, then only pass the catheter, because the guide wire is very small. Where it can subintimally, we can again pass the wire into the patent part of artery. So once we are confirmed by the cross flow of the injection, then only pass the catheter. This is very important. So once the wire is gone and the catheter is gone, then it becomes a fast track. So again, your guide wire will go again into that fast track. So once we are confirmed by the cross flow angio, we are in the true lumen, then only pass the catheter. Then we can take the when blood is coming back from the main catheter, then we can take the angio. Then after we crossing the wire, we did the balloon. We didn't in this case, because this is the external iliac artery disease. We directly go with the stent, because after balloon angioplasty, there are the certain cases that report the external iliac artery very prone to rupture. So generally we put directly do the stenting of the external iliac artery rather than do the pre-ballooning. So we did the stenting first, and then after that we do the ballooning, just to take care of that we do not rupture the external iliac artery, because it don't have any media. It only have the advanced here. So we only did the stenting first, then the balloon angioplasty. So this is the flow after the. So we left the patient only at this stage only, and then we call the patient after 2 weeks to treat the distal run of disease. So again, after 2 weeks, we take the anti-grade approach. So we are able to cross again from that crossover approach, and from the right side approach, we are able to do the angio. This is the disease. This is the BTK disease. This is the posterior artery. That is ventral PCI. Before 2 weeks, we have done the angio. We are not able to visualize the ATA, PTA. These collateral are not formed. Within 2 weeks, after the inflow disease is correct, the patient have the formation of the collateral and visualization of this ATA and PTA vessel. So now we can have the better result by doing the BTK angioplasty. So this is the importance of the time giving to the patient after 2 weeks. So he can develop the collateral. So we can have the better result in the second sitting. So rather than doing the case in the first sitting only, we can divide the. So after the first sitting, patient chest pain is completely gone. He was able to walk, but ulcer was not healing. So then we started with the second. We again after 2 to 3 weeks we again take the patient. But by anti-grade approach, we are not able to cross this lesion. Then we take the retrograde puncture of the posterior artery. From the posterior artery, we are able to negotiate the wire into the popliteal artery and the distal SFA. We do the balloon angioplasty. After the balloon angioplasty, we are able to, there is a complete, relatively formation of this posterior artery is patent, and there is a filling of the peripheral artery is also there by collaterals. So good result is there in the BTK disease. So this is the basic concept. When patient is having such a large burden of disease, don't treat it in the first sitting in the same disease. This is another case with a similar history. 55 years old male, since he having gangrene of all the digits since 1 month. He have a smoking history from the 25 years, no complaint of diabetes, hypertension, because they are typical Berger disease patient. Doppler finding reveals severely compromised flow in the right common femoral artery, SFA artery, and below the knee arteries. CT angio reveals a long segment occlusion of the right common iliac artery, external iliac artery, extending the proximal part of the common femoral artery. So this is the similar type of the patient. So in this case, we first try with only with the anti-grade approach only, rather than the retrograde puncture. Let's see whether we are able to cross with the anti-grade puncture or not. So we are able to cross the anti-grade approach, the wire of the common femoral artery. Then we place as we generally don't inflate the balloon in the external iliac artery. We directly put the stent in the external iliac artery. Because of the I was assisting this the resident because of some mismanipulation, the wire goes out of the stent. So we are not able to do the balloon angioplasty of this stent. This is the Innova stent of the Boston. The wire was come out while taking out the balloon, while taking out the stent. The wire was come out. So we are only in this stage the stent. So in this case, approximately 50% of stenosis. So we are not able to post angioplasty the stent. So we must be thinking whether we are what will the result after the stent placement. So we kept the patient for heparin after 1 or 2 days. So we kept then after 2 weeks, we again called the patient for the reprocedure of the BTK. And after 2 weeks, without angioplasty, there is a proper stent was fully expanded without any angioplasty after 2 weeks. This is the Innova stent of the Boston that we have used. So these are the adequate stent. Even without angioplasty, without any ballooning of the stent, there is a proper expansion of the stent after 2 weeks. So this patient also had the BTK disease. So there is adequate collateral formation. Initially angio, there was no feeling of the ATA and PTA, nothing else. So after this inflow disease correction, there is adequate flow of the adequate visualization of the PTA and ATA arteries. So we have to do the PTA puncture by the retrograde approach, and only this segment was remained that has to be opened up by the balloon angioplasty. So after 2 weeks, we are able to open it with the retrograde approach. I mean, initially this AT was also not visualized in the previous angio, that was visualized. So this balloon angioplasty was done by the retrograde approach. This was the adequate visualization of the ATA and both PTA was flowed. A patient was healed with a gangrene and his pain was gone. This is another patient of 65-year-old male with severe resting pain in the left lower limb with gangrenous changes. On examination, feeble femoral pulse with no pulse in the popliteal artery and infrapopliteal artery of the left lower limb. Doppler revealed absent flow in the distal SFA, popliteal and infrapopliteal arteries and left lower limb artery. CT angio revealed low attenuation of the left external iliac artery, SFA, long segment of the. This is all these are the type D lesion of the. So this is the very long segment disease. From the distal SFA, nothing was visualized till the BTK. So we took the antegrade puncture in this case. The multiple collateral formation and nothing was visualized. The formation was seen in that very faintly in that peroneal mid part of the posterior artery. So we have taken the retrograde puncture from the retrograde approach. These are the. Then we were able to cross the balloon into the distal SFA. We do the balloon angioplasty till distal SFA. We generally took the wire into the antegrade sheath and then we do ballooning from the antegrade approach only. So rather than doing the ballooning from the retrograde approach, we do the ballooning from the antegrade approach. After ballooning, this was the segment which was showing the dissection. This was not flow was established, but this segment showed the irregular flow. After the ballooning, so we put the another stent in the from the distal because this patient having the disease in if I will to show it from the distal SFA till the popliteal artery, ATA, bifocal tubular trunk, and the proximal path of posterior artery. Approximately 25 centimeter long segment disease was there, but we put the stent only in the distal part of the this segment of the disease artery because the popliteal is very smooth. So we did not do the stenting of the popliteal artery because we can see here we can see the popliteal artery in this image. It's very smooth. So no need to stent the popliteal artery or putting the superior stent across the joint here. Rather than we put the straight with this stent and I see the adequate flow to the vessels. And there is adequate collateralization of the this AT and PTA both are filled. This is how it is after the stenting. Because this segment was very we are able to negotiate with very struggle. So we have multiple dissection in this thrombus segment. So this patient is fine. His rest pain is recovered and the gangrenous changes are recovered fully. This is another ATS female with right toe thick blackening. So basic point is that we don't to stent all the arterial segment, all the occluded segment. We have to only after the balloon angioplasty, we have to only stent the segment that is have the that's all the dissection, flow limited dissection. We have to only stent those segment only. This is the 40 years female with right toe blackening and severe pain in the right lower limb since 1.5 months. Known case of diabetes and hypertension, typically atherosclerotic disease is there. These have diffuse disease from the SFA to popliteal artery, from the ATA and BTK artery. CT angiography revealed the extensive mural thickening with the calcification. This patient have the extensive calcification in the both lower limb arteries. This is the extensive disease in the BTK arteries. Even the femoral artery is also very diseased. This ATA, PTA is faintly visualized. They have the mural thickening calcification. ATA is very partially visualized. So we did only the ballooning by antegrade approach only of the ATA and the distal femoral artery and the proximal femoral artery also. After that, this is after the angioplasty, the femoral artery. This is after the ballooning of the. Even we have to balloon of the proximal femoral artery also because the whole SFA was diseased from the SFA to the ATA disease. This is after the ballooning. After the this is after the antiatibial artery ballooning. Adequate visualization of the antiatibial artery. So we have done only by the antegrade approach only, by antegrade taking by antegrade puncture. This is a 75-year-old male, blackening of the right toes and severe resting pain for 2 months. Referred to us by Department of General Surgery. No history of smoking, trauma, previous treatment was there. Patient was diabetic from last 25 years and was on the oral hypertension. Doppler showed the absent flow in the right and mid SFA with monophagic waveform in the distal SFA. Inferior arteries. CT angio reveals the attenuated caliber of the right CSFA, long segment occlusion of the proximal SFA, DSA. This patient also has the long segment occlusion of the SFA that is extending from the proximal part of the SFA. The little deformation in the distal part. This patient also have the BTK disease also. This patient also has the narrowing of the proximal part of the SFA. We have to do, first we have to do the ballooning of the proximal part of the SFA. Then in the mid part. So we were able to establish the flow to the in this case, then we place the stent. We are able to go to the infrapopliteal part. This is after the stenting because this part is only this part is showing the disease segment. So we have the place in the stent only in the distal segment of the distal part of the SFA rather than covering the whole vessel. This is another 48 male patient with who has the typical symptom of Berger disease, history of hypertension since 10 years, and of medication use. The CT angiography revealed the long segment occlusion of the distal SFA. Then this is the via antegrade approach. We are able to do the angio from the mid SFA, the whole of the artery is occluded, and these are the collateral which are formed. In this case, we are not able to cross the via antegrade approach. Then we have take the retrograde puncture in the posterior tibial artery. From the posterior tibial artery, we are able to negotiate into the distal proximal SFA. Then we did the ballooning from the retrograde approach. Now after ballooning, we put the stent, but in this case we didn't have the proper little bit shortening of the stent was there. So we are not able to cover the lesion. The proper length. That's why the little bit certain area was left behind this area. This caused the thrombus formation within the stent.
ये सब थ्रोम्बोसिस है।
क्या चीज होगी यार, कुछ भी नहीं आ रहा है।
After the thrombus formation, there was no flow in the below the knee artery, nothing.
एक आठ पहले 3 आठ भर
There was no flow in the below the knee artery, nothing. No ATA, PTA, nothing was visualized. Then we do the ballooning again. A little one streamline flow was established. It was again blocked after some time.
ऐड कितनी वो है, क्या चीज होगी यार।
So this patient had the instant thrombosis. So after that we kept the patient for heparin. The patient had developed a severe ischemic pain because the thrombosis of all this collateral was gone. We kept the patient for the catheter-directed thrombolysis for 2 days, but nothing was there. His globe extended up to the profunda arteries. Only profunda was patent. whole of the SFA was blocked. Then we left the patient and we kept the patient for 2 to 3 days for IV heparin. The patient have the relieved the symptom of the pain, and then we are recalling it after 2 weeks. Again, we do the angioplasty, and again we do the procedure of this case. This is another case for 35-year-old female with blackening of the right toes and severe resting pain. This is a very young female who comes with the no history of diabetes, hypertension, no history of any smoking. She has a thrombotic disease of the SFA, very small. Only the proximal part of the SFA was involved in CT angiography with attenuation of the distal SFA. As we take the crossover sheath and we take the angiogram,
मैंने से इतना ध्यान भी नहीं दिया वो है उसमें
the
चिपका
whole of
रहेगा
that
हम
is
देखेंगे
DSR
नहीं।
slowly
frontal
का
femoris, and
अच्छा, ठीक है।
there's a distal deformation of the superficial artery SFA. Only the small segment is there which is not filled. So we will say it's a very easy case. We are able to do it, and we will go by the integrated approach and we will connect it. And we put the wire in the profunda just to see or make sure that if anything happens, so we at least we have the wire in the profunda, so it will not occlude the profunda by ballooning of the SFA. So while doing this case, so we have the from the crossover sheath. While taking the angio, we did not attach the actually saline flush to the crossover sheath. The large thrombus which was formed within the sheath was extending to the external artery. So everything was gone, no flow in the profunda.
नहीं अब कल
Try
करेंगे
to, this is the thrombus formation
नहीं PTUD कल करेंगे
that was
उसको ना
gone from the sheath. So we will try to
PC में
aspirate the
उसके बाद
thrombus by the
उसी
guiding sheath, taking 6 times guiding sheath. So we will try to aspirate more. We try to aspirate. It was again occluding the more of the thrombus was more extending to the proximal part of the external artery. So it was just coming nearby to the bifurcation. We thought we aspirate more. So we will block also the internal artery also. This is a young female, 35 years female only. So nothing was gone. Only the internal was patent. Whole EC was gone. So we tried more. We tried to aspirate more. It was extending proximally. Then we used this. We have solitary stand by aspiration. Nothing was coming out. Thrombus was coming out, but it's causing more spasm and recurrent disease. Then we use the solitary stand just to. This is the solitary stand. So then we use solitary stand to capture the thrombus multiple times. So it was able to capture the thrombus. A little deformation was there. At least we are able to patent the external artery a little bit, but profunda was not patent. So at least we are able to cap the patent to the ECA. We capped this patient for IV heparin for 3 to 4 days. 1000 units per hour, and she was.
मनी लग रखेंगे यार आपसे
So this was the ECA after.
मनी लग रखेंगे यार
Then we left the patient over here only.
External
We will not do further any
revisionist
escalation
part
because
का।
that will complicate the further disease. So ECA is patent, some collateral was formed. Then we took the patient after 5 days again for the let's see what's happening. So the external artery is patent. It's left where we left. It is up to there only. Then we go by the anterior approach only. So this time we use the ultrasound guidance also. Whether we didn't take the wire into the profunda because it was already thrombosed, and we try to negotiate wire to the SFA in the ultrasound guidance to modify the catheter. So we are able to close the wire to the SFA because it's very fibrotic disease. So it takes very long time to pass the guide wire into the SFA. After SFA, we did the only 3.5 millimeter balloon we used for the balloon angioplasty. At this time, we took the 014 wire rather than taking the 035 wire. And then after that, this is the deformation site. So in the initial angio, the deformation site was very proximal. Like in this angio, we can see.
मैंने से इतना ध्यान भी नहीं दिया वो है उसमें चिपका रहेगा
ऐसे बात
हम
नहीं,
देखेंगे
DSC
नहीं।
वाली गोली का ध्यान रखा करो
Only
ना
5 centimeter gap was there. Now after this thrombotic disease, this is the deformation of the up to distal SFA. We have the thrombus formation from this proximal external artery to the distal SFA. We have the extensive thrombotic disease. Then we do only ballooning only. Again, after ballooning, we have this segment of the artery which is shows those only 5 centimeter segment which are initially shows the thrombotic disease only show the irregularity. Rest of the SFA shows the proper flow. Only this segment shows the faint opacification. So we put the stent only this segment of the artery. This is again after the ballooning. This is after putting up the stent. So this patient is now defined the pain that this patient had the severe pain after the occlusion of the profunda artery. She was in severe pain for 2 to 3 days. So we still kept patient on the IV heparin, keep monitoring her. Then again we take for the DSA just for the because she is having severe pain, not improved by any medication. Then we have to take for the DSA within short time, within 5 days. Then we have to be able to stand this, and the patient is now patient has a pain has totally improved. So these are the cases. Okay.